Hi everybody. Today's topic is mecentric ischemia and we'll discuss about it. Coming to classification of mecentric ischemia. In mecentric ischemia we have acute mecentric ischemia and chronic mecentric ischemia. In this board, acute is the most common. 95% of cases will be acute, 5% of cases will be chronic. In acute we have arterial occlusive, veno-occlusive, non-occlusive and strangulating bowel obstruction. These are the causes of mecentric ischemia, acute mecentric ischemia. Arterial occlusive, there is a problem within the artery. It gets blocked by emboli or thrombi. Veno-occlusive, there is a problem within the venous system. Non-occlusive, and one more is strangulating bowel obstruction, due to bowel obstruction indirectly leading to the obstruction of the vessels. Then coming to clinical importance. When the patient comes with acute mecentric ischemia, the most common symptom is pain. It will be very severe. In chronic mecentric ischemia, once the patients have food, there will be postprandial dull abdominal cramps that last for 1 to 2 hours. So this leads to patient avoiding to have the food, leading to unintentional weight loss, and they also have early satiety. Laboratory tests neither sensitive nor specific. Coming to importance of age, the mean age in cases of acute mecentric occlusive acute mecentric ischemia is 70 years. Okay. Normally it is in older people. So when this occurs in younger patients, we have to rule out any predisposing condition. This is very important. It can be due to emboli or other predisposing conditions like vasculitis, collagen vascular diseases, hypercoagulability, vasoactive medication. So this is very important. Younger patients, before going into imaging findings of mecentric ischemia, most important is anatomy. So first is the celiac axis. Celiac axis, it arises from the aorta at the level of T12 and L1 level. So what it supplies: stomach, proximal duodenum, liver, pancreas and spleen. Now we'll see what are the branches of celiac axis. So it arises from the aorta at the level of T12 and L1 level. It gives off left gastric artery. One of the branches is left gastric artery. Left gastric artery gives off gastric branches and esophageal branches. Another branch is the common hepatic artery. It gives off hepatic artery proper branch and gastroduodenal artery. From the hepatic artery proper, we get right gastric artery, left hepatic artery and right hepatic artery. Right hepatic artery gives rise to cystic artery. From the gastroduodenal artery, we have superior pancreaticoduodenal and right gastroepiploic artery. Splenic artery, it gives branches to pancreas. Short gastric artery, branches to spleen and left gastroepiploic artery. Left gastroepiploic artery, it anastomoses with right gastroepiploic artery. So these are the branches of celiac artery. Coming to superior mecentric artery, it arises from the abdominal aorta at the level of L1, L2 level. It gives branches to distal duodenum, mecentric small bowel, that is jejunum and ileum, and right colon. So what are the branches of superior mecentric artery? Superior mecentric artery, it gives inferior pancreaticoduodenal, it gives branches to jejunum and ileum, middle colic artery, right and left branches. Right colic artery, it has ascending and descending branch. Ileocolic artery, it has superior and inferior branches. So what are the branches of superior mecentric artery? We have jejunum and ileal arteries, inferior pancreaticoduodenal artery, middle colic artery, right colic artery, ileocolic arteries. Then coming to inferior mecentric artery. Inferior mecentric artery, it arises at the level of L3 and L4 level. It supplies distal transverse colon, sphenic flexure, descending colon, sigmoid colon and upper rectum. What are the branches of inferior mecentric artery? Inferior mecentric artery arises at the level of L3 and L4 level. It gives sigmoid branches, left colic artery, superior rectal artery and terminal branches. So these are all the branches. Then coming normally upper rectum is supplied by inferior mecentric artery. The middle and lower rectum are supplied by branches of the anterior division of the internal iliac arteries. Another important, the vascular pathways between the mecentric arteries provide essential blood flow in the patients with vascular stenosis and occlusion. Right. For example, there will be a collateral pathway between the celiac axis and SMA. That is between pancreaticoduodenal arteries. That is celiac axis, common hepatic artery, it gives gastroduodenal artery. From gastroduodenal artery we get right superior pancreaticoduodenal artery. From celiac axis we get a superior pancreaticoduodenal artery. From the SMA we get an inferior pancreaticoduodenal arteries. There is anastomosis between them. One more is arc of Buller. This is the arc of Buller. This is a celiac trunk. This is a SMA. There is collateral pathway between them, anastomosis between them. This is called arc of Buller. Then between SMA and IMA, there is marginal artery of Dermond. There is anastomosis between terminal branches of SMA and IMA along the inner margin of the colon. This is SMA. These are terminal branches of SMA. This is IMA. These are terminal branches of IMA. This anastomosis between the terminal branches is the marginal artery of Dermond, and it is along the inner margin of the colon. So one more is arc of Riolan, that is anastomosis between the arc of Riolan, that is anastomosis between the middle and left colic arteries. This is the left colic artery, this is the middle colic artery. Anastomosis between them is the arc of Riolan. Coming to venous drainage, SMV, that is superior mesenteric vein, IMV, inferior mesenteric vein, they drain mesenteric venous blood into the portal venous system. Jejunal veins, ileal veins and right middle colic veins, they drain into the superior mesenteric vein. Superior rectal veins, sigmoid and left colic veins drain into the IMV, and which in turn drains into the SMV or splenic vein. So we have superior mesenteric vein, splenic vein, they drain into the portal vein. Here the inferior mesenteric vein is draining into the splenic vein. Coming to CT imaging technique, we have multiplanar biphasic CT angiography of the abdomen and pelvis should be done. So when a patient comes with abdominal pain, you are suspecting any vascular abnormality, CT angiography is done of the abdomen and pelvis. We have arterial and portal venous phases are taken. Non-contrast phase or sequence. So first you should take a non-contrast, then arterial and venous phase. In non-contrast you can see a mural hemorrhage, atherosclerotic calcification, baseline bowel attenuation. So normally 1.5 ml per kg of hyoexol is given. Rapid injection rate of 4 to 5 ml per second followed by saline solution flush. This is the normal protocol. Normal positive oral contrast material is not recommended because it obscures the bowel wall enhancement. Thank you.